The topic for this presentation is conjunctival degenerations. We will be discussing Pinguecula, Pterygium, and Concretions, starting with Pinguecula. A Pinguecula, plural Pingueculae, is an innocuous but extremely common asymptomatic elastotic degeneration of the conjunctival stroma. A yellow-white mound or aggregation of smaller mounds is seen on the bulbar conjunctiva adjacent to the limbus, as it is seen in the figure here. It's very characteristic. It is more frequently located at the nasal than the temporal limbus, but is frequently present at both. Calcification is occasionally present, as it is seen here. The change of color. The cause is believed to be actinic damage, similar to the etiology of Pterygium, which Pinguecula resembles histologically. The distinction is the limbal barrier to extension has remained intact with the Pinguecula. Though transformation can occur, occasionally a Pinguecula may become acutely inflamed, called pingueculitis, particularly if the lesion is prominent or overlying calcification leads to epithelial breakdown, as it is seen here in this picture. This will result in a little bit hyperemia, which will be localized. Treatment is usually unnecessary because growth is absent or very slow. Irritation may be treated with topical lubricants. Pingueculitis can be treated with lubrication if mild or with a short course of topical steroids. Excision may be indicated for cosmetic reason or for significant irritation. In contrast to Pterygium, the recurrence rate is low and simple excision is usually adequate. Thermal laser ablation can be effective. Gentian violet marking may be necessary to ensure adequate absorption in lighter skinned individuals. The next one is Pterygium. A Pterygium, plural Pterygia, is a triangular fibrovascular subepithelial ingrowth of degenerative bulbar conjunctival tissue over the limbus onto the cornea. It typically develops in patients who have been living in sunny countries and, as with Pinguecula, may represent a response to UV exposure and to other factors such as chronic surface dryness. The condition tends to run in families. A Pterygium is histologically similar to Pinguecula and shows elastotic degeneration changes in vascularized subepithelial stromal collagen. In contrast to Pingueculae, Pterygia encroach on the cornea, invading the Bowman layer, and Pseudopterygium appears similar clinically but is caused by a band of conjunctiva adhering to an area of compromised cornea at its apex. It forms as a response to an acute inflammatory episode such as chemical burn, corneal ulcers, especially if marginal, trauma, and cicatrizing conjunctivitis. Clinical features include symptoms. Patients who present with a history of recent enlargement are more likely to require early excision for subsequent aggressive growth. Aggressive growth or an atypical appearance should prompt excision biopsy. Most small lesions are asymptomatic. Irritation and grittiness are caused by a Dellin localized drying effect at the advancing edge due to interference with the precorneal tear film. More likely if the head of Pterygium is especially elevated. Patients who wear contact lenses may develop symptoms of irritation at an earlier stage due to edge lift. Lesions may interfere with vision by obscuring the visual axis or inducing astigmatism. There may be intermittent inflammation similar to pingueculitis. Cosmesis may be a significant problem. Extensive lesions, particularly if recurrent, may be associated with subconjunctival fibrosis extending to fornices that may cause restricted ocular excursions. If pseudopterygium is suspected, there may be a history of a causative episode. On examination, a pterygium is made up of three parts: a cap, which is an avascular halo-like zone at the advancing edge, a head, and a body. As it is seen in the figure here, this is the avascular edge. A head in, then there is a body on the conjunctiva. Linear epithelial iron deposits or stalker line may be seen in corneal epithelium anterior to the head of pterygium. It is seen here. Now, Fuchs eyelets are small, discrete, whitish flecks consisting of clusters of pterygial epithelial cells, often present at the advancing edge. A pseudopterygium is classically distinguished by the fact that the location is away from the horizontal, though this may occasionally be seen with true pterygia, and that there is a firm attachment to the cornea only at its apex, that is the head. Now, this is an example of pseudopterygium. Its origin and extension both are different from true pterygium. Treatment is both medical and surgical depending on the size and extent of the lesion. Medical treatment of symptomatic patient is same as for Pinguecula. The patient should be advised to wear sunglasses to reduce the ultraviolet exposure. Surgery is simple excision, which is bare sclera technique, and it is associated with a higher rate of recurrence, which is around 80%, often with more aggressive behavior than the original lesion. There you can see the surgical process of the pterygium removal. Here you can see the conjunctiva. This area is of bare sclera. The pterygium is removed from the cornea and from the conjunctival area. And if we leave it there, this is the bare sclera technique. And but in this case, there is 80% recurrence. So this is not a preferable technique. Conjunctival autograft, on the other hand, the donor conjunctival patch is usually harvested from superior or upper temporal paralimbal region, as it is seen in the second picture. Here, a donor conjunctiva is taken from, and the graft is then sutured into the position using 10-0 nylon sutures, as it is seen here. It is sutured. The site heals rapidly. Conjunctival grafts can be secured with tissue glue, for example, tussle fibrin glue, rather than sutures, thus shortening the operating time and reducing the post-operative irritation. Adjunctive treatment with mitomycin C or beta irradiation can be used in place of patching techniques. Peripheral lamellar keratoplasty may be required for deep lesions. In patients undergoing surgery for pterygium, the risk of recurrence can be reduced by using either a conjunctival autograft or by applying mitomycin C to the operation site. Next one is concretions. Now, concretions are extremely common and are usually associated with aging, although they can also form in patients with chronic conjunctival inflammation such as trachoma. They appear as multiple tiny cysts containing yellowish white deposits of epithelial debris, including keratin, commonly located subepithelially in the inferior tarsal and forniceal conjunctiva. They can become calcified, and particularly if large, may erode through the overlying epithelium, as it is seen in the pictures here. The yellowish markings here. They are eroding through the conjunctiva, and here as well. And this can cause irritation. If symptomatic, treatment involves removal at the slit lamp with a needle under the topical anesthesia. So this is it with the conjunctival degenerations and their treatment. If you like the lecture, please press on the like button and subscribe to the channel. Thank you all.